Welcome back, everyone. So this week we're joined by Dr. David Erritzoe. David is both a psychiatrist and the clinical director of the Psychedelic Research Centre at Imperial College in London. One of the centre's main focuses is researching the use of psychedelic drugs to treat mental health disorders, and that's exactly what we focus on today, in particular on their potential use in depression, though the centre also conducts research into conditions such as anorexia and also addiction. We talk about our current understanding of how psychedelic drugs might work, their safety, and the importance of the context within which they're taken for their antidepressant effects. I really enjoyed hearing about how David's team overcome some really interesting hurdles relating to this research, in particular how to conduct clinical trials for drugs which are illegal, even for medical use, and how to ensure adequate blinding in placebo-controlled trials of drugs with psychedelic effects. We talk about research into microdosing, the idea that small doses might be effective at treating depression, and also compare psychedelic drugs to other drugs used to treat depression. It's certainly a really exciting space to keep an eye on in the future, so I hope you enjoy the episode. Brilliant. So David, welcome on the podcast. Thanks so much for joining me. It's a pleasure to be speaking with you.
Thanks for inviting me.
I'd like to start off at the beginning. We're going to chat a bit about the use of psychedelic drugs and the growing interest and a bit of a revolution in our understanding of them and our understanding of what they could do for medicine in the future. But I'd just like to start off by asking, what sets them aside from other drugs? How do we define a psychedelic drug?
Yeah, the psychedelic drugs are quite different from most of the other drugs that people use recreationally. They differ in particular because of the effects that they introduce. They produce this sort of psychedelic states that can go into peak psychological experience where people have this profound sense of awe, bliss, insightfulness, meaningfulness that can be used therapeutically. They can also be very challenging and psychologically very challenging and overwhelming because material can come up through these experiences that can be very valuable and interesting therapeutically, but can also, if done in a very uncontrolled setting where people are maybe not supported through it or afterwards, can be very overwhelming. So they differ in that aspect massively from other drugs that typically introduce a very pleasant state, a degree of euphoria, also calmness that most other recreational drugs do. And importantly, most other drugs, if we think about stimulants or opiates or alcohol, one of the main problems with those drugs is that they can really make people becoming completely dependent on them, which of course then leads to all these problems that people with addictions have. Whereas the psychedelics, they do not tend to do that. It's sort of more spread out experiences that people can have, sometimes very, very few experiences in a lifetime, and they don't have that feature of making people crave them and urge them and seek them all the time, and they don't create that cycle of dependence. And one of the reasons might very well be that they work pharmacologically through another system in the brain. They stimulate receptors in the brain's so-called serotonin system, whereas a lot of the other drugs, we know, the stimulants, opiates, they stimulate other systems of the brain, such as the dopamine system and opiate system and so on. So pharmacologically they're different, and also then therefore their risk profile is different. The risks are mainly related to these overwhelming psychological experience that they can lead to for some people if it's not supported.
Are we concerned about repeat use? Are we concerned in that sense? Because it's kind of my understanding that lots of people are using them, I guess, relatively sporadically in comparison to some what we call kind of drug addicts, probably because of the lack of dependency. Do we know much about what happens when people use them repeatedly?
In terms of repeated use, some people use them more than others, and definitely a repeated use pattern, but it doesn't come into this sort of complete lack of control, loss of control, which is classic for development of addiction. So it doesn't go to those heights. What we are probably more concerned about for very regular use of psychedelics is that it might be pushing people into a very repeated, very flexible, open state that can probably be quite confusing and not necessarily very productive if the experiences and the psychology is not worked through the experiences, if they don't settle in and they're not integrated into a person's life. But if they're too frequent, that psychologically might not be very smart. And another thing, pharmacologically, they stimulate the very psychedelic receptor, which is the serotonin receptor called 2A. They also stimulate other receptors such as 2B receptors, and they sit in the heart valves, for instance. So very, very frequent stimulation of that receptor has in the past been shown with other pharmaceuticals to produce some fibrosis of the heart valves. So really, really frequent use of the psychedelic needs to be tested, probably in animal models, to see whether some of those problems could arise from very frequent use. But I don't think anybody with an insight into how psychedelics are being used or should be used would recommend anybody from very, very frequent use. But there's a phenomenon called microdosing, where people do use small doses much more frequently.
And hopefully we'll get onto that a little bit later. So overall, would you say that these drugs do seem to be pretty safe in comparison, certainly say psilocybin, is reasonably safe in comparison to lots of the other drugs that are used around the world and are not classed as illegal, alcohol being one of them, for example?
Yeah, there's no doubt about that. They are physiologically much, much safer than a lot of the drugs. If we speak about the classic psychedelics, there are also some more novel synthetic psychedelics that seem to have some health safety concerns. But if we speak about the classics, and here I'm mainly speaking about psilocybin, LSD, DMT, mescaline, they are physiologically very safe. Apart from this little potential concern about the 2B stimulation on heart valves, but that does not seem to be of importance and of massive concern with very sporadic experiences with these drugs. And then, as I mentioned, the biggest concern in terms of safety lies within the psychological space, that they can be challenging and difficult and evoke difficult emotional states that can be perceived as incredibly overwhelming and almost traumatic if a person is not really prepared. Typically, a very young person who's maybe experimenting with drugs and suddenly end up on a random LSD trip without being really in an unsafe, potentially not supported environment. And if that becomes a bad trip, it can almost be a bit traumatizing. So people, but if people use it in a safe way, they typically are much safer than most other compounds. Even when we use them in therapeutic and experimental context, we can also say that side effect wise, they actually look quite good. Also, when we compare to pharmaceuticals that are used to treat mental health, not to say that these drugs are going to replace everything that we know and we're using in psychiatry. I'm also a clinical psychiatrist, but they do look quite good in terms of side effect profiles.
So this idea that the context in which you take one of these drugs is very important, and what you just mentioned here about perhaps clinical use brings us on to nicely some of the work that you're doing at Imperial. So could you tell me a bit about that? What sorts of interests do you have there?
Yeah, so together with the team there, the group is headed by Robin Card-Harris, and we have a really, really great group who all are working hard on a number of studies. So some of the recent studies, I mean, we first did a pilot a few years ago, where we, in a small group of patients with treatment-resistant depression, tested whether it was safe to let people in such a vulnerable state go through psychedelic experiences with oral psilocybin administration. And that trial worked really, really well. It was an open label pilot trial, so it was not, randomized blind trial, but it gave really very positive and very promising results, that people had great effects on their depressions. And that has then led to more trials coming after, including one where we are doing a little bit better design, bigger sample, where we randomize people to SSRI, so normal conventional antidepressant treatment with a gold standard SSRI for 6 weeks, versus a couple of experiences with psilocybin assisted therapy. So that we are soon gonna come out with the results from, and looks very, very interesting. And then other people around the world have initiated big multi-center trials. Industry is coming into play. There are new companies starting up that are launching big multi-center trials in order to see whether, when you scale it up, whether there are effects that will then make them go through to being licensed treatments in the future.
So when we're talking about antidepressant effects and the ones that we're hoping to be shown in clinical trials coming up, what sort of effects are we seeing? Because on one hand, from drugs that have already come through, we've got SSRIs, which seem to take several weeks to actually kick in their effects and then last for a while as you keep on taking them. And then we've got ketamine, on the other hand, which seems to be very rapidly acting but doesn't last as long. Where do psychedelic drugs fit into this?
Conventional antidepressants, such as the SSRIs, they work really well for some patients, but there's still 30-40% who don't respond really at all. So, which is what we sometimes call treatment resistance or difficult to treat. And then multiple different things will be tried, but there's still a big hole there where there will be people who still struggle with their depression or anxiety without getting much benefit from these drugs. And also, it has been put more and more sort of emphasis onto this experience that people have being on antidepressant for a long time, that some people struggle a bit in the phase where they're trying to wean off them and get some kind of withdrawal syndrome or discontinuation syndrome where they have unpleasant experiences trying to get off the medications. So there is definitely a space for new, interesting treatments to come in there. And then ketamine is a relatively new, even though it's a medicine that have existed for a long time, but in the space of psychiatry, it's a relatively new thing that has been licensed to treat, again, difficult to treat depression. And you're right, it has short-acting effects, and then it requires then repeated dosing, so not daily, but a couple of times a week, maybe for a while, and then maybe once a week, maybe once every second week. And when we compare to ketamine, no study has, as far as I know, been done yet one-to-one comparing them in a perfectly designed trial. But it seems from the data so far that the psychedelic experiences, and here mainly talking about psilocybin, seem to have quite long-lasting effects probably because these very profound psychological peak experience seem to be very productive in terms of therapy and make people go through some changes that have long-lasting positive effects on their conditions. And that's a bit different from ketamine, because you're right, it doesn't look like single experiences with ketamine have equally long experience. It needs to be tested even more stringently in the future, more one-to-one. But the psychedelics will probably be used fewer administrations than the ketamine, and of course way fewer than the daily medication with SSRIs. It will be a few experiences, maybe with months between, as it looks right now. It might not be the one experience for more than a few people. Will have really, really long, many months or years. So it's difficult to imagine complete magic bullets that will just pull people with treatment-resistant depression forever out of their depression without some top-up experiences with these drugs over the time. But the models look like it's going to be significantly less frequent than the ketamine administrations.
And that seems to be really good when we're talking about side effects as well, because certainly conventional SSRIs, as you mentioned, are not without any side effects at all, particularly in some patients.
Yeah, you're right. They have some people actually do not have side effects at all from SSRIs and really tolerate them well and have really good effects, because I think that's important to say, because that really is the case. But some people do have some quite unpleasant side effects. Often it's just in the beginning, gastrointestinal kind of side effects, but people can also have sexual side effects, and also some people feel a little bit like, running around in a sort of strange confined space and there's a lid put on. Some people experience like that. Again, not everybody, because some people actually more feel that the lid of the depression has been taken off if the SSRIs really work for them. So it's a different treatment model, pharmacologically different. It's not that the psychedelics directly affect the transmission of serotonin. They more go in and sort of do the same thing in a quite sort of powerful way as serotonin would do on some of those receptors.
Continuing on, when we're assessing antidepressant medications, we talked about side effects a bit, and the next obvious questions are, how large an effect do we see in depressed patients, and in what proportion of them as well with the psychedelic drugs from the research that's out so far?
I don't have the numbers in my head, unfortunately, but it looks really, really good. The effect sizes look very, very convincing in these early pilot studies that are published so far, including our own. However, when you look at effect sizes and see, oh, how amazing does this look, you can, first of all, you can look at before and after treatment, how big a drop and in how many. But if it's not blinded to a placebo-controlled, control condition, then, because you can also think about effect size as the difference between how does the drug compared to a complete placebo arm work. That's a different way of calculating effect sizes, and that will be the important work that will come out in the future when that is done. In our own new trial, we'll have that kind of data. It's not out yet, and also the big multicenter trials will also produce that kind of data that will be even more important and convincing if it looks good. And we know already our trial looks very good, but so when it comes to these early effect sizes, if you don't have a placebo control, they look really, really, really good. And it looks like the vast majority of the patients in these trials, they really benefit. However, there is also some degree of selection bias in an early phase of such a kind of controversial therapy to bring in. It will obviously appeal to some specific patients who might have had more negative experience with previous treatment and so on. So therefore, that's why it needs to be scaled up and used in real world populations so that you will actually have a more true picture of kind of average normal patients without being too biased towards a specific treatment who will go in. And that will, be important for the larger scale trials that will come to see whether the results look as good. My guess is that they will still look good, but they might not look as good in the very early pilot trials. It's almost too good to imagine.
Well, better that way around than the other way around. My question leading on from this is, how do you adequately control with a placebo for a trial like this? Because it's certainly a very dramatic experience being on psychedelic drugs. And that's obviously, if you use, say, a sugar pill, that's probably going to be something that's very noticeable whether you're on the placebo arm or not. So do you use active placebos at all?
Yeah, I mean, it's a very good question, because there's an obvious problem about properly control a trial using a psychedelic experience, because it is quite a unique sort of experience. And then if you use a sugar pill, you're right, you have a very inactive placebo. And if you try to if people are psychedelic naive, they haven't tried psychedelics, but they won't necessarily know what it is to expect. So if you give something with some kind of subjective experience related to it, could be niacin, a vitamin that gives a little bit of a flush to the face. It could be a low dose of a stimulant, could maybe even be a benzo. But the thing is, the 5-hour long nice music thing on a benzo, I think most people would fall asleep. So that probably is not brilliant as a placebo. Could also be that you test it directly with ketamine. And you could also, as we have done in our recent trial, do it one-to-one with an already existing therapy. And you're right, then of course, if you are then in the SSRI arm, and you do not get, then you get a minuscule dose of psilocybin, you will not really have an experience on that dose. But the whole setup, the way people are expecting it going into the sessions, the things that happens around the sessions will be the same. So that is probably as good as we get. You can also use different doses of psilocybin if it's psilocybin you want to test. So you can do a tiny dose and a medium dose and a proper high dose, and then you can see whether the groups split in the outcomes. That's another way of trying to get around this. But it's right, you probably can't conduct the perfect experiment as you more can do with an antibiotic, for instance. That is pretty easy to really well placebo control. That's very difficult with these drugs. And it was already a problem in the 50s, 60s with the first era of psychedelics, how to do these trials the best way. That was actually in the period in the early 60s where you came up with gold standard ways of testing new drugs with proper double-blinded placebo-controlled trials. And that clashed a bit with the psychedelic paradigm, because it's very difficult to actually apply such a model to that paradigm. That actually another a bit alternative explanation of what kind of went wrong for the field in the first era, because if you suddenly want to apply that model to this new at that point new field of psychedelic assisted therapy, then you will fall short because it's not really possible. You need to come up probably with different kinds, as I just mentioned, different kinds, and see if it all works. And no matter how you try to do it, it comes out favorable for the psychedelic therapy, then it's probably good enough. But yeah, as long as the side effects are low enough as well compared to other treatments.
And certainly there are stories from decades ago of trials where experimenters actually took LSD with the patients taking it as well.
Yeah, but you know what? There is some underground therapists around the world who even still now, I think some people probably still use that model. That's not gonna happen in in the established system, and it's not how we run our trials, and it's not how the companies who are developing these medicines and these treatments are using it either. But there are underground therapists also using MDMA assisted therapy, where the therapists are on MDMA with the clients, and it's a very tricky model, also ethically very complicated, and probably not the way to go for this more conventional route that we are on.
Exactly. So overall, just going back a tiny bit, would you say that actually we're hoping for such an effect size, or we're expecting to see an effect size with psychedelic therapy, that actually some of these issues with making a perfect placebo-controlled trial shouldn't be as important? That actually the trials we are designing are sufficient, even if they're not perfect in terms of blinding patients to the treatment that they're getting.
Definitely, and also importantly, the regulatory bodies such as the FDA in America, and also in the UK it would be MHRA and the EMA in Europe. So those are the the bodies that control and monitor and approve, and in the end license new treatments, and so they have been on board with these companies, and so it has been done in communication, very clear communication with them. What will be good enough for this to go through? If the results are good enough, what design do we need to? So it has been developed together with the authorities, which is very much the right way. When you come with such a kind of different new paradigm, you need to make sure that you're not running a trial that no matter what it shows, nobody would ever, license it afterwards. So it has been done smartly and meaningfully together with these bodies that need to be involved.
And speaking of actually using them, you mentioned the going through a 5-hour process. Would you be able to just outline exactly how these drugs are used in these trials? It's not the case of just giving somebody a pill and then sending them home, or sending some in the post. It's actually quite prescribed, isn't it?
Yes, absolutely. So it's very different from if in a normal drug trial you would include your participants, your patients. You would then randomize them into groups, and you will give them without you or the patient knowing whether they get placebo, or and then they just take the medications at home, and they will be sort of monitored and checked in with and so on. In these trials, and also how the future is going to be, and also how people even underground are using these therapy tools, it's different. First, you need to carefully screen people, make sure they're kind of ready and prepared well for these experiences as well as they can be, and ready to sort of surrender and go into the this sort of profound experience that it can be. And it's done in a very, very supported environment. So the drug experience is not something that people are given a pill and then sent home to have the experience at home. It's done with the guides and therapists present in the room, preferably probably with one of each gender in some of the trials. That's how a lot of the therapists who are experienced in this field, of course, a lot of people can't be that experienced because it's relatively novel, but there are also the early experiences from the first era that having one of each gender present in the room all the way through the experience, and the same people involved in the preparation phases of the patients, and then ruling out that the patients have a history of psychosis, often even first degree relatives with a history of psychosis, in order to keep the risks as low as possible. And then there's the integration work psychologically afterwards, after having gone through the experience. Then there's some meetings with the therapist where it's work towards trying to make sense and try to integrate these experiences so that they optimize their therapeutic potential and the duration of their effects. And so it's much more than just the pharmacological experience. It's really a psychological experience together with a quite heavy psychological context that needs to be in place. In most of these early trials, the psychological therapy element is minimal because we're just giving the support around the experience without giving any proper therapy. In the future, it will probably be integrated into more proper therapy that suits the psychedelic experience. So probably not very, very cognitive models, but sort of other models such as the ACT model or different models will be tried, also depending on the patient population.
And how do you go about actually designing the context with which people are taking these drugs? Because it seems like we've added an extra dimension here. When we're normally considering drug trials, we think of the dosing, the pharmacokinetics, its availability, for example. But here you're adding in something else on top of that. How can you almost design that without having multiple arms of your trial? Or do you have multiple arms testing different contexts and tweaking them?
It's a very important question. And there are, of course, a lot of different routes to go down. If you really wanted to really test how important the context is, it would be tempting, and that was done in the 60s, to take the context away and basically just put people in a room, giving them the drugs. They're on their own. There's nothing supported about it. However, that's not very safe because of the psychological nature of these experiences. They need to be kind of gently supported in order for them to be contained and feel safe for the participants. So that's very difficult to take the context away. You can do that with microdosing. So with microdosing, it's much safer psychologically to experiment with the context and the setting. However, with full doses, that's probably not the route. So instead, you can then have your control condition with the exact same context. So people will still be lying in this room that is constructed for the psychedelic experience, but they won't have the psychedelic experience. They will just be in the room with the same degree of interaction, the same inputs, the same, even though it's a bit difficult to sort of, hold the experience if people don't have experience, but the same degree and level of contacts with the people, the guides, therapists in the room. And then maybe have the same music, obviously, the same setting, because the setting is often made quite pleasant visually. Although people most of the time are wearing a blindfold and listening to music on headphones, there's also music out in the room. And the room is designed in a very pleasant way with dim light and something that can be stimulating to look at in the periods where people will be looking out into the room. And all that can just be kept intact and maintained also in the control condition, so that you keep the context, because the only other alternative is to take the context away, and that's not safe.
So on the other hand, you mentioned earlier potentially traumatic effects. Could we see the opposite effect if somebody has quite a bad experience taking one of these drugs, actually, that it can shift their psychological phenotype in the opposite direction for extended periods of time?
I don't think anything can be completely ruled out. And if you had asked me this 6 years ago, I would probably have been very cautious in what I would be saying. But now we have several trials having been conducted by our group, but also by a number of other brilliant colleague groups around the world. And when we look at all those trials together, that has just not been the case. I mean, people can have quite challenging experiences through the experience, but because it's so supported and there's the integration phase after, even if they have been challenging, maybe sometimes it's just part of the experience that's very challenging, sometimes it could be even the entire experience, but despite that, it's still safe and people are not traumatized because it's sort of contained from the therapist and the context, and it's worked through. So therefore, even though it might have been a challenging experience, it doesn't seem to, in any of these trials, come out as a traumatic experience that people actually, become worse from after these. Whereas out in the real life, there are people who are quite traumatized from psychedelic experiences. As I mentioned earlier, if you haven't been taking them in a sort of supported setting and you're not probably prepared and wasn't followed up, if it was really challenging, you need to work through it with somebody. And if that's not done, and that is what is applied to all the modern trials, and therefore we haven't seen those things in the modern trials, fortunately. If you then suddenly do it to 1 million people, can I completely guarantee that there won't be a couple that actually could be traumatized. I can't rule that out, but we just haven't seen it now in hundreds in these trials.
And certainly there's perhaps a degree, given and we'll go on to talk perhaps about the political landscape around this, but perhaps a feeling that we shouldn't be holding these drugs to way higher standards than we would other drugs because of their history behind them and their associations and the views that many people have on what was originally a recreational drug. And actually we can hold them to far higher standards than we would ever hold a novel antidepressant.
No, absolutely, you're right. The tradition of developing normal medicines like normal new antidepressants and so on, there's not much emphasis put on the context at all, although there are actually very interesting trials where people are looking at the combination of a safe psychological space while you treat people with drugs that induce sort of increased transmission if you're in your serotonin system. If you have that in a very, very unsafe, very unstable, and very maybe psychologically difficult period of your life where everything around you is chaos, that might not be brilliant. And there are some studies showing that even combining the normal SSRI treatment with therapeutic psychological therapeutic package might be more than 1+1. In some trials it shows that, and in these trials that is the whole core of the new paradigm, that the context is incredibly important. So you're right, it will need to be conducted to quite high standards, and also the companies who are wisely developing these, they are very aware of that, and that is kind of part of the model that they are developing and trying to license. It's not just that they're going to produce the drug and sell the drug and a GP can then prescribe the drug, or any therapist can do it. It will be the package, the safe package with the context that needs to come with it. So you're right, it will be, the idea is to use these medicines to quite high standards when it comes to all the packaging around it.
You mentioned microdosing earlier, and the question that I had leading on from this is, to what extent are the psychedelic effects of these drugs necessary for their antidepressant effects? And what do we know about this?
Yeah, that's a really also good and very important question. So the question about what role does this profound psychological experience that they can induce in full doses, what importance does that have for their therapeutic potential? And therefore, how would microdosing then work? Because they are kind of sub-perceptual. The idea is that they are so low, the doses, that they do not give these proper psychedelic experience, definitely not even close to a peak psychedelic experience. So in all these early trials, including our trials, we can see that the nature and profoundness of the actual subjective experience on the full doses in these therapeutic trials, they seem to predict the therapeutic outcomes. Whether that's a trial related to smoking cessation by our colleagues at Johns Hopkins or our own in depression, it really seems quite as a consistent finding that the nature of the experience seems to be important. Then, if you then go to microdosing, then it becomes quite confusing, because how would that then work? And there, I guess, it sits between a psychedelic line of work in terms of science and then more conventional idea of testing a new drug, because you have repeated dosing, which is much more similar to normal conventional therapy with medicine, and you have a repeated effect on the brain system. Might be low doses, but we know that despite that we are in the range of microdoses, psychedelic microdoses, they still have proper pharmacological effect, in the sense that the sort of effect on the 2A receptor in the serotonin system is actually quite significant, even in the doses that people use for microdoses. So it is, conceivable that they could have pharmacological effects in those low doses based on what we can measure in brain imaging in terms of occupancy of the receptors. But is the nature of the experience important? If microdoses work, then probably can't be that important in the paradigm of microdosing, because it's not really there. But could a repeated or frequent stimulation of the 2A receptor, for instance, in sort of low to moderate degree, could that be therapeutic? Some studies of SSRIs shows that some of the effects of SSRIs probably are mediated through this psychedelic 2A receptor. So it might not be completely out of nothing that you can imagine that stimulating that receptor more directly with psychedelics, even in microdoses, might have some important therapeutic effects on their own. So at the moment, the science of microdosing is relatively in its early days. It's relatively weak evidence so far. There's some studies that are small, that have been quite controlled with very, very few doses, where it doesn't look like it does much. Then if you look over longer time, then you have other studies, but they have been more observational without having the placebo condition built into it. They look incredible. They look like, okay, microdosing leads to improved cognition, it improved well-being, it stimulates focus, attention, it improves memory, it improves creativity. However, all that is very anecdotal because it's done without the control condition. And if people really believe and expect this will, change their life and be great, and they will go back to their Google job and be much more creative and come up with great ideas, then there's a massive element of potential placebo built into such a thing. You also sort of belong to a very popular new subculture. It's almost an identity. You talk about it with your friends and your family and at work. It's part of your new identity that you are now a person who's microdosed. It has all the elements of massive placebo effects. So it needs to be tested in proper trials, which is much easier than with the full dose for the reasons we spoke about earlier. It's easier to placebo control microdosing. It's just quite expensive because it's still Schedule 1 drugs, for instance, in the UK. So you would need to have people coming into a lab many times. And maybe potentially they have to stay in the lab until the effects wear off, even though they're tiny doses, it's still the same half-life. So you need to have people maybe stuck in a lab many days, and that might be quite interruptive for people to participate in the trial, very expensive to run the trial. So we have come up with a model where we can actually go in a more naturalistic space where people through online survey can blind themselves by following a manual we have developed, and therefore actually enter into a potential placebo control if the manual make them take placebo rather than their own drug in the period of the microdosing over 4 weeks.
Okay.
So that trial we have developed, and we are submitting that for publication very soon. And that's in close to 200 people who then were on their own initiative, microdosing, using their own drug, but then they signed up and consented to do it on their own initiative on our platform, and then the platform then allowed them to blind themselves, potentially. Some of them would then be taking microdoses for the entire period, others would be taking placebo for the entire period, and other people would be taking 1 week placebo, 1 week microdose, and so on. And then they wouldn't know. And then there's a barcode or a QR code that they could scan in with an app on their phone. And then we actually have the information of what they took in what week. So we can see what they took, but they can't. And then they can be unblinded in the end and get some results if they're interested when they're done with the trial. And that we're soon going to publish. So it's a very quite fascinating new model where we quite cheaply can investigate, at least build up some early evidence. Does this look like it works, or does it look like it does not work when people microdose?
And I imagine at this stage you're still faced by the selection bias there, that we are selecting for people who have likely taken these drugs before and are up for taking them, and probably have a particular demographic as well.
Yeah, you're absolutely right. That is exactly why the placebo condition is completely key. Because if you have the placebo condition in and people are well blinded, then it doesn't matter at all who you include. It could be completely psychedelic enthusiast, but if they are blinded well and they don't know what they take, then the results are going to be important, because they will then be randomly distributed to the two arms of the study, and therefore it doesn't matter too much. And in such an opportunistic, naturalistic online survey trial as I'm describing here, we can't at all direct who's going to sign up. It probably will be people who would. It is people who are planning it on their own initiative. So it's not that we go out and pick people randomly and then include them in our trial. It will be people who seek such trial themselves. But the beauty of this kind of design is that you then have the placebo condition in. So so basically you would expect that probably both arms would improve, and that's also what we see, because people are already very pro and very interested and have great expectations and they want it to work, therefore it does work. But does it work better than placebo or does it not? That's the
Indeed.
$1 million question. And how well are they blinded? And and also we even in this trial we asked them to guess whether each time they had a dose, we asked them to guess later in the day, do you think that you actually had a dose of microdosing today, or do you think it was placebo? So we have all that information sitting in one trial, and that makes quite an interesting trial because we can actually really address the expectation, the breaking blind effect, and whether it seems to work beyond the levels of placebo.
And is this patients self-reporting their psychological symptoms? Because patients are, as you mentioned, taking Schedule 1 drugs. Is there still a degree of stigma? I imagine you have to follow quite close to you, kind of concerns about anonymity.
Yeah, in this kind of trial, this has been a global survey, so everybody all over the world could basically participate, and people just needed to sign up with an email. So it was in that way pretty anonymized, sort of pseudo-anonymous. We didn't even have the information of what was their name, phone number, date of birth, anything. We just needed them to sign up, and then they filled out a lot of questionnaires, obviously, at baseline before they started the microdosing and all the way through. So at baseline, we got a lot of information about why did they do it? Do they have a history of this and that? Different scales assessing their degree of well-being at baseline, the degree of symptoms related to depression, anxiety, if they had any such, use of drugs, previous history, previous experience with psychedelics, all that we can assess online, but we don't need to know who they are. And then they consent to the trial before they give any such information. And then the email, the only link to them is then reminding them to go in and fill out stuff along the course of the trial. So in an online survey, in this case, very opportunistic, naturalistic, prospective survey, if that makes sense. You can't control who is in the trial, and you don't want to in a way, because if let's say you get thousands of people in such a trial, there will be people who at baseline actually have above a threshold, so they actually would be depressed patients. Some of them would be healthy people, but then you have different scales, so you both pick up change in depressive symptoms. You have what is more relevant for healthy people, a well-being scale that is a validated scale that you can use to see whether there's an increase or change in their well-being, and then also some potential negative impacts of the microdosing also put in there. Do they become a bit manic? Do they become more paranoid? Is there anything like that? And also personality measures. We can also do online neurocognitive tests, looking for memory tests where they play games online that we had then get the results from, attention tests and so on that we can do. So it's not just scales that people fill out questionnaire, it's also actually testing them online.
And I imagine it's also hard if you wanted to send a Schedule 1 drug in the post to people to actually control exactly what's in it. They're using their own drugs in here.
They are using their own drugs. Absolutely. So we would definitely never be allowed to send them any drugs, even though a lot of the people who signed up in the beginning, they were like, "Oh, when is the drug arriving?" Because they hadn't read the details too carefully. So they just hoped they got some LSD in their mail for the trial, but it was their own drugs. But then we have the opposite problem: that how can we then know what they put into their capsules in this trial, because it was their own drug? So we can only rely on what they believe they bought on the dark web or wherever they got it from. If they dry map mushrooms, it's a bit more precise probably, because the range is not massive in terms of uncertainty about how much psilocybin is there in that amount of dried mushroom.
And certainly if we're talking about microdosing, then I imagine there's a range. I'm not sure whether it's an order of magnitude or not in terms of what dose you would accept or what dose you're preparing for there.
Yes. So people typically follow guidelines and manuals coming from a colleague in the States called Fadiman, who has written some books about microdosing and done a lot of investigative, so anecdotal collection of evidence for microdosing. And people are typically following that way, advised by his work. That's typically what people do. So people aim for between 5 to 10% of a full psychedelic dose, whether it's LSD or whether it's dried mushroom material. They go for 5 to 10% of a full dose typically, and then that's what they then use a couple of times a week over the course of 4 weeks typically. For this trial, we acquired the data for 4 weeks and then had a follow-up after additional 4 weeks. But of course, people could cheat. People could also accidentally think that they had a great blotter full of LSD, but they could have been, I don't know, lying in the sun for 10 years before they used it, and could be maybe completely without any LSD in it. And so in a trial like this, it would be massively beneficial for us to be able to measure at least some participants' drugs to get an idea whether what they report actually is what was really in the drug that they were using. That has been quite difficult for us to get approvals for. So that's that's an Achilles heel for this line of work, that it's very difficult for us to get access to measure people's drugs. But it might be possible in future trials.
You've got quite a lot of experience in brain imaging. And from this perspective, what do we know about the potential mechanisms by which psychedelic drugs could be benefiting patients with depression?
I mean, there's more and more imaging work done. Yeah, some of it from our own group, and also colleagues are doing great work with imaging now. And some of the things we can see is that during the acute state with the full dose, the functional networks of the brain, something we can measure and try to understand using MRI, so magnetic imaging, we can see that some of these networks are behaving quite differently. So the networks that are related to our own free line of thought, self-related, ego-related thinking, who are we, what did we do yesterday, what are we going to do? That network of the brain, some of the connections, functional connections within that network are broken down in the psychedelic space. And also that network that kind of represents self-related thinking is suddenly being connected with other networks in the brain. So you have that, this sort of melting of the self-related networks with other networks of the brain during the acute psychedelic state. We can also see, if we look with EEG, we can see that something called alpha rhythms are going down, related to letting go of the ego and the almost disintegration of the ego during these peak experiences. So we can also see some of those correlates. We can also see a higher degree of chaos in the brain activity. So entropy of the brain related to the state, we can see that. So yeah, we can also measure the direct occupancy of this very psychedelic receptor, the serotonin 2A receptor, that is very key for the action of the drugs. We can see that the intensity of the experience is directly related to how many of the receptors are being affected by the drug, so that there's this dose response relationship that we can actually measure in terms of occupancy on the receptor. So all these things are making us understand a bit more from study to study, but we are still trying to figure it out. Also because one thing is what happens in the acute state, which is in itself deeply interesting, but another thing is what happens to these network more longer term. So we have another trial soon being published, the data from where we look at follow-ups with imaging in people who have never tried psychedelics before. We see what happens around the experience and then what happens in the later phases, try to understand these long-term effects better.
Because ultimately that's the real excitement, that long-term antidepressant effects could be achieved with these drugs. A 5-hour dosing regime for 24 hours, for example, of improved mood isn't necessarily viable for a long-term treatment plan.
No, so you're right. So we need to try to understand. First of all, we need to understand, for some patients, are these experiences and this therapeutic, effect that you see very early on, very acutely, how long lasting are they? And who are they lasting the longest for? What predicts that? Is that related to personality factors or mental health related acute factors of where people are? Is it how easily they are to surrender to these experiences? A lot of things that we are looking at. We can also use the online surveys to look at some of that, which we are doing. And then, so what about the people where it might be really, really short lasting? What predicts that? And then the mechanisms. what happens in the brain, can we actually understand the brain mechanisms better to see if it has those long-term effects on some of the networks. For instance, if we think about MRI, is that important for the duration of the effects? So all that we are trying to understand. And even let's say that we don't have the tools, even though we have fancy imaging techniques, we have PET, MRI, EEG, it's all great, but it might not still be that all the details and important things that does potentially change in the psychology, that we necessarily have the tools to pick up the neurobiology behind such changes. We can probably only see some of it, and if we can get consistent finding that can be repeated between trials, then we will really believe that these might be a fingerprint of what are the mechanisms behind these therapeutic effects, and are predictors of the duration of these effects. But it might also be that the tools might not be sensitive or smart enough at this point to really kind of uncover all of that. So we only have the tools we have. They're much better than they were, but they're constantly being developed as well, all these methods.
You published some research looking at imaging of the serotonergic system in particular. So yeah, there's definitely some things to look forward to in the future. And it's also certainly true that all of the guidelines and definitions of depression, whether it's the ICD or the DSM, give the possibility for a range of different symptoms coming together in the depressive phenotype. It's certainly a very heterogeneous condition. So I'm sure there are questions out there over, as you said, exactly who could benefit from these drugs and what sort of factors are actually relevant when we're looking at predicting the effects of these drugs.
Absolutely, and in a way it is a bit of a weakness of how science is conducted in general in mental health, that we are often, most trials have to be conducted not to satisfy the authority who will have to sort of approve the studies and approve licensing of drugs. You have to sort of stick within the DSM or ICD criteria and so on. But it might, you're absolutely right, there could be a very little overlap between patients fulfilling criteria for diagnosis within a category, and therefore there are other ways of looking at science and conducting and designing trials where you might not do it that way, but you might look at other phenomena that might be actually sharing a bit across different conventional diagnoses. For instance, you could look at reward deficiency, impulsivity, other kind of the aspects that are not diagnosis, but you could have that across different conditions. And there's some work over the last couple of decades from the NIH in the US looking at something called the RDoC criteria, so research related criteria where you basically use neuroscience to define domains or phenomena that you can actually then include populations into your trials from, rather than conventional diagnosis. And that might be highly relevant to psychedelics because they seem to have very promising results from a range of mental health conditions, whether it's eating disorder, actually we don't really know yet, but we are designing that, whether it's anxiety disorders, OCD, addictions, alcohol, nicotine, and probably also other addictions, or whether it's proper depression. And therefore you could think about trials where you have a different way of including people into the trials, where you don't just do it based on a pure ICD or DSM diagnosis. And I think that might enrich our understanding and the literature in the future. And we are definitely trying to head in that direction if we can.
I've said throughout this that we should get on to talking a little bit about what the political landscape around this is and the legislation that surrounds psychedelic drugs. Could you tell me a bit about what sort of space we're in currently and how this has affected research into using psychedelic drugs medically?
Yeah, so in the UK, these psychedelics, they're classified as Schedule 1, which basically means that they are not for medicinal use, and that makes the research more tricky because you need special licenses and a lot of approvals to be able to access and research them, do science on them. Whether that's going to be rescheduled at some point, it might very well be. If these trials come out, then it would be difficult to claim that they don't have medicinal use anymore, and therefore they maybe will be rescheduled. I'm not really much involved in any of that because it's more sort of political and legal aspects of it, but of course it affects us. In terms of the recreational use, the regulation there, they're also illegal drugs to use. Whether they would be declassified and made a bit less illegal in a country like the UK, whether that happens, I don't know. I think there are movements in other places of the world in that direction, both for psychedelics and also sometimes for other drugs. You have decriminalization happened 18 years ago or something like that in Portugal. And you have a lot of lobbying at the moment in several states in America trying to make some of these compounds basically legal to use. And it has happened, as far as I know, in Denver. There are different initiatives in different states in America. So there is a movement in that direction. It's not really probably in the position I'm in to push that, also because we have plenty to do with the science and the development of these medicines. So I think, that in a way that the science probably will not completely do its job by itself, but I think if the data is really strong and it looks like this is something that actually can really help a lot of people when it's done in the medicinal way, then I think the legislation should be changed to accommodate that, and I think that will happen. Otherwise, it will seem quite obstructive. The recreational use is a difficult thing to think about, because if you legalize drug use, whether it's psychedelics that are, as we have talked about, quite safe drugs and might be therapeutically, is that maybe actually going to backfire on, because if people use it in a really, really uncontrolled, unsafe manner, could that produce a lot of trauma that could be avoided by not? So I'll stay out of that discussion because it's a heated one, and also I don't feel it's actually that I'm the expert in that aspect of it, because of course it has massive consequences to make drugs legal or even decriminalize it. The data from Portugal, from doing the more sort of in between thing, which is decriminalized, that the data look really good, and that's all drugs in Portugal, and that all their stats have changed in a much more positive direction, basically all of them, over these last 18 years. So there's that model to look towards when it comes to how to deal in a legal system in a society with recreational drug use. You can also do tons of other things. You can do harm reduction things where you allow people to have their drugs tested and so on. That doesn't mean you have made them legal or even decriminalize them, but at least allow people to have a behavior that is safer, which is harm reduction. That's also very meaningful. Some countries are doing that with a lot of drugs. But anyway, I think that the movement is towards making access to these drugs, if the results hold, at least in the sort of medicine part of this question. But
there's a much stronger case for drugs which are a lot safer, and as we discussed before, don't induce dependency to the same level. If we compare it to, let's say, morphine and fentanyl, both opioids which are used prolifically in hospitals, but are both Class A drugs nonetheless. You can see different circumstances in which they wouldn't necessarily have to be legal for them to be medically used, but then also,
not at all,
as candidates for legalization, it seems almost that we can be applying some double standards to the drugs that are currently illegal and were maybe made illegal for reasons that weren't based on the science behind them.
You're right, but I guess, as you mentioned, the opiates, you have this sort of strange thing that you have drugs that are used in the hospitals and by doctors like myself that are prescribed because they have, indications, they have meaningful applications in the health system. Dexamphetamine is a drug you can prescribe, which is basically a speed, right? And you have ketamine, which is also a medicine. You have some cannabinoids that can be prescribed. You have, benzos that are not too far away from alcohol in their effects. So all these medications do exist, but that doesn't mean that it's legal for people out in society to use them as they please in a recreational matter. Because then that becomes a really big and difficult question, because it has so many implications if you change those laws. But at least you have some wiggle room in terms of declassifying and making them into other classes, and that probably is quite relevant in the case of psychedelics in the future. But that's not really my agenda to sort of push that. I think I'll leave that to other people who are sort of lobbying or coming from politics and the legal world, rather than me as a scientist and as a medic. There will be a movement in that direction, I'm pretty sure.
Just quickly, who actually makes these drugs then? If these are classed as Schedule 1, then where do they come from? Presumably you can't order them on Amazon or normal drug markets.
Yeah, I mean, if we do our online service where people basically use their own drugs, some of the studies that we conduct online, they work like that. And then people can get them from wherever, from the dark web, or they can go to the forest and find some mushrooms if it's the seasons for that. Or
I imagine Imperial College doesn't like you foraging out in the woods for magic mushrooms.
No. Even it would be quite a lot cheaper for us to do it that way. But no, we get it from labs. And in the beginning, we could get it from labs because a lot of these drugs are produced by a few labs, particularly for sort of preclinical work, so lab studies in cells and animals and so on. So they have always been kind of produced by different labs, but not necessarily to the standard for clinical trial use. Now there are these new companies who have been starting up who are then getting the licenses to produce these drugs up to the standards that are needed for clinical trial use. So that has now happened for some of the drugs, which of course is a good thing for academia, because then we have access to the right level and right quality drugs to do our academic trials as well. So it is happening, and those companies, they are obviously doing it in completely legal way. So they get the licenses to synthesize, produce these up to the standards, and then they use them for their own trials. But then they also collaborate with academic groups like ours in order for us then to use their compounds that are produced the right way for our trials. So that's how it works at the moment. And of course, if it's only one single company who do it, then they have a bit of monopoly. There are a couple of different companies that's probably better for academia, because then you can collaborate with the different companies depending on what the conditions are and what the purpose of the trials are, and it gives more opportunities for everybody if there are a couple of different players who can produce the drugs. And that is what we're seeing now, that there are more and more who can do that, which is great.
And certainly if legalization were to take place somewhere in the world, it'd be very important to have suppliers that can produce it safely. Otherwise, you can imagine almost releasing the floodgates, and suddenly the only available sources of psychedelic drugs are the very ones we're trying to discourage people from getting them from in the first place by legalizing them.
True, but I mean, if you had psychedelics overall being legal, then you would just have people legally using very safe mushrooms, and probably not necessarily needing to get the drugs from. Then you could have people sort of try to farm some of these. It's not plants, but mushrooms or truffles, and that's happening in Holland, where you have truffles that are legal that have psilocybin in them. So there you have an industry related to that, and similar could happen everywhere in the world. If these things were legal, it wouldn't have to come from these companies who are producing it up to the standards of clinical trials. I don't think they would start selling it out into the street, because they are also protecting their model to make sure that if it's used under their model, it will be done safe with the right package. That's what they are developing. So if they start selling that out into shops, but just because it did that I don't see happening. I mean, this is a business case I'm going into. I don't know, but that would be strange as I see it. I don't think that's what they want to do.
That makes sense.
Yeah.
Well, I think we're probably just about out of time now.
Yeah.
But we've delved into all sorts of things in this discussion. It's been fascinating for me, certainly, to research here. So I went to one of your talks, which first inspired me to actually get in contact with you about this a few months down the line. So all I can say right now is thank you so much for chatting with me. And good luck with all of your future research. I think it's certainly groundbreaking stuff, and we'll see a lot more of it in the next few years.
Brilliant. Thanks a lot for having me on, George. It was a pleasure.
Thanks for listening to the Pager Podcast. If you've enjoyed it, do leave us a review, share it with a friend, and come back to listen to our other episodes. As ever, we'd love to hear what you think. You can reach us at Pager Podcast on Instagram and Twitter, or email us at pagerpodcast@gmail.com. Bye for now.